This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Shuvro Roy from the University of Washington, and welcome to today's Neurology podcast. We're joined by Riley Bove from the University of California, San Francisco, to discuss her recent article published in conjunction with teams from the University of Virginia and Virginia Commonwealth University in neurology clinical practice. The article is titled Multiple Sclerosis and Family Planning, a Survey Study of Patient Experience. Now, addressing management of MS pre and post-conception poses challenges, certainly, and we have this combination of limited safety data, a lack of clear consensus guidelines, and on top of that, what really is a constantly evolving landscape of available disease-modifying therapies, each of which carries their own considerations for family planning. Riley, this study was so fascinating to me. You all collected data from before the 2000s, during the 2000s, after 2010. What sort of information specifically were you hoping to gather in this study, and how did you decide which questions to ask?
So this really represents a labor of love for Mila Goldman and her team. So starting off at UVA and then moving on to VCU as well. And patients were sent questionnaire at UVA between 2011 and 2016, and then at VCU between 2015 and 2021. And so the questionnaire asked about their pregnancy experiences, decision-making. It had quantitative responses. It also had qualitative responses. And then all of these surveys were completed and received and compiled in 2022. And so overall, this represented 282 responses. And so the team really sifted through this to try to extract nuggets of information that would reflect childbearing decisions, childbearing experiences, and the role of the neurologist's team in shaping these.
Why were you and your colleagues motivated to conduct this survey?
Pregnancy experience, family planning, and figuring out how best to optimize therapies is really one of the big treatment-related decisions and counseling-related decisions in the disease course of individuals with MS of childbearing potential. And as you mentioned, there are really a lot of unknowns. And one unknown is specifically around what counseling to give and whether it makes a difference. And so some of the aspects of the study that I'm most excited about are the fact that it was done at two very different places that have different patient populations and that also represent different decades. So we can really look at some ways in which that real-world experience has changed over time.
That was really one of the most compelling aspects of the study to me was, certainly you captured several populations, but the fact that you were able to capture information across multiple decades and give this longitudinal view of how the patient experience has changed over time, I think is what's quite exciting and certainly worth a read. You mentioned that there's this really large lack of information on the topic, and I'm curious, what information were you specifically hoping to gather in this study, and how did you decide which questions to ask?
So one of the big questions was whether patients had a pregnancy after their MS diagnosis and what factors went into that decision-making process. The second question was around unintended pregnancies. Do we see the same rates of unintended pregnancies in this MS population as we do in the general population? Regarding counseling, we wanted to understand what effect pregnancy-related planning had on choice of medications, and then also how many patients even just talked about pregnancy planning with their neurologist. So these were some of the questions that we asked.
And what were your big picture takeaways?
We found that a large group of patients did not have pregnancies after MS diagnosis. On average, that group of patients' age was about 38 years at diagnosis. And for about 20% of those patients, the reason had to do with MS. So they were concerned about MS worsening due to pregnancy or about MS compromising their ability to care for their child. For 80% of those people who didn't have pregnancies after MS diagnosis, the decision was kind of unrelated to the MS. We also found about 20% of patients who did have pregnancies after their MS diagnosis. And these patients tended to be younger and they tended to have more children overall. And among those patients, it was great to see that about 70% did have their neurologist discuss pregnancy plans with them. And over time, that tendency increased. So if they had pregnancies before the year 2000, only about 40% of them had their neurologist talk to them about pregnancy. If their pregnancies occurred between 2000 and 2010, 65% of them had had a conversation with their neurologist. And if their pregnancy occurred after the year 2010, 83% of them had a conversation about pregnancy planning with their neurologist. And so really these numbers increased with each decade. And those are really encouraging that we're seeing changes in neurologist behavior and counseling of women of childbearing potential with MS.
And so we're going to dig into some of those results in greater detail. But before we do, I'm just curious, were there any of those specific findings that surprised you?
The overall finding was very encouraging. I think what was not necessarily surprising but disappointing is that even these patients who were diagnosed and who were considering pregnancy in recent decades, some of them still had received discouragement from medical professionals about becoming pregnant. And so that was, I think, concerning for us, and it's disappointing. The other piece that was really good for us to be able to measure was the rate of unplanned pregnancy. We tend to really advocate for pregnancy planning, family planning in multiple sclerosis, just avoiding situations where there's unintended drug exposure or a pregnancy that happens when the patient's sort of MS isn't optimized. And so the rate of unplanned pregnancy that we observed was 27%. And that was surprising to us sort of in a positive way because it's lower than the national average. And it suggests that there is some planning and maybe access to family planning and thought about that. And that's what we'd want to see.
There was one topic I wanted to start with in terms of diving into in greater detail, and it was sobering to me. And that was something you mentioned right off the top, which is about 20% of patients reporting that they chose not to become pregnant after their diagnosis because of their MS, or rather citing their MS. And that these patients were younger than those who avoided pregnancy for non-MS reasons. Could you elaborate for us the different factors that influenced women's decisions regarding pregnancy after they were diagnosed with MS?
We really don't know a lot about these pregnancy-related decisions and MS-related pregnancy avoidance. There's a really nice paper that came out of Dessa Sadovnik's group in Canada. What we learned is that patients who chose not to have a pregnancy after their MS diagnosis because of MS, some of them were concerned about MS worsening during pregnancy. And of course, we know that typically patients with MS feel quite well during pregnancy. And sometimes they say that their MS symptoms even kind of go away. And that it's more in that postpartum period that we worry about postpartum relapses. Some patients were concerned that MS would compromise their ability to care for a child. And so there has been historically this idea that, you don't want to put a child into this world that you may not be fully fit to take care of. But certainly we still see concerns around things like fatigue, which we know is just so significant for many of our patients. And of course, childbearing and child raising is, very fatiguing as well. And so that is a concern that we expected to see. There are occasionally people who are afraid of the genetic load of passing on MS to their child. And so that's an important area area of counseling because we know that absolute risk is low, even if there is a risk of passing on MS. And then other patients were really kind of apprehensive about their medications. Would they have to stop their medication and how would their MS do in that situation? And so all of these concerns, I think, really reflect what we see in clinical practice and where we've really sought to increase evidence and counseling points to try to address so that we can support pregnancies for people with MS who would otherwise want to have another pregnancy.
And from what you're saying, it sounds like much of what could be addressed certainly could be addressed through education. As you mentioned, the expected disease course, for example, during pregnancy, and the concern that the disease course may worsen or MS become more active when we know that generally that tends to be the opposite. And of course, that risk of passing on MS, even if it's from a first degree relative, is, something around, only 3%. And so it sounds as though counseling could go a long way to address some of these concerns. And that was really just perfectly teed up for my next question, which is another interesting set of results to me was about counseling and pre-pregnancy care for patients with MS over time from, say, before 2000 versus the 2000s and then 2010 till now. Across these three epochs, we saw a greater proportion of patients with MS were counseled on their plans for pregnancy, as you mentioned before. How has guidance on family planning, pregnancy, and postpartum care for women with MS evolved over these last few decades in your mind?
I think these epochs really reflect the state of the field as well. And so it's really nice to be able to see how things change as the sort of data change. And I think with respect to pregnancy and MS generally, the scientific literature ignore, the demographics that many of our individuals diagnosed with MS are females of childbearing potential, right? I think the field moved from just kind of wishing pregnancies just didn't happen, so we didn't have to deal with them. And the sort of false ethics, the false morality of do no wrong, because without counseling, without planning, we really are exposing patients to either not having the completed families that they were hoping for, or just getting, pregnant without full knowledge of the risks and potentially even lack of risk of some of the medications, right? So just saying, well, we don't want to talk about it, wasn't actually serving the needs of our patients. We've seen us really understanding better how the MS trajectory changes during the immunotolerant state of pregnancy and how better to manage that risk of postpartum relapses. We're really moving towards being able to support breastfeeding and many individuals who want to breastfeed. And we're moving also towards what we call active management, where rather than getting all the way off therapies and exposing patients to potential risk of relapses or even rebound relapses with some medications, we're able to really optimize the windows so that patients are treated as actively, as effectively as possible while reducing the risk of transfer to the fetus or to the newborn through breast milk. So I think those are the ways in which our field has changed. And we see that really reflected in what the patients in different epochs reported, where they had more counseling in more recent decades, where there was some move towards medication, active management, treatment optimization. We had some interesting findings related to breastfeeding as well. And I think all of this is really nicely reflected. And it just suggests that what we're doing on the research front is translating into clinical care. And I think that's really exciting to see because it doesn't always feel like that. I think some of the key themes to go over in the pre-pregnancy planning phase is what comes down to this key question, the one key question. Does the patient intend to get pregnant in the next few years? And that's just a really important question to reevaluate, even in people whom, for whom we think we know the answer, because life changes and partnerships change, identities change, goals change, finances change, and all, jobs change. And so I think with all this, we have to stay up to date with the patient's plans. If they do not plan to get pregnant, then certainly just revisiting one of those handy CDC CDC flyers that talk about the efficacy of the various contraceptive methods is really important, and just going over that with the patients. If they are planning to get pregnant, then really reminding them that there is a checklist of prenatal things that are recommended for all people, such as smoking cessation, weight optimization, mood management, taking prenatal vitamins and folate, things like that. And then, of course, I think in the MS world, the big decision is really around two things. Is the MS stable, and what to do about the medications? Generally, you want the MS to have been, the disease activity to have been quieted for 6 months, 12 months before pregnancy conception attempts. And then you want to really try again for active management. And there are evolving guidelines about when to stop or whether to stop each DMT. And so I think picking up the most recent of these guidelines, we have some out in Lancet Neurology and Neurology Continuum this year, but certainly those continue to evolve with the field just for the specific medications. One of the therapies I love are the B-cell depleting therapies, because you get these really nice windows during which patients are protected from relapses, but the drug is not on board. And so there's this nice PK/PD optimization where patients can go into their pregnancy feeling fairly comfortable with their disease activity and really being able to focus on the pregnancy itself. When you get to the postpartum period, again, some of the key differences from routine pregnancy management are just when to restart the therapies and which ones are compatible with breastfeeding. We've seen a lot of evolution in those data. And so actually a lot of the medications are quite reasonable to consider during lactation. And if people are not up to date on that, they can always check out LactMed or other reputable sources. Also, just focusing on that postpartum period as that fourth trimester where patients are at risk of relapses. They're also at risk of increased depression, anxiety, and also they have rehabilitation needs, mental health needs, fatigue needs that are not always met. And so really planning to see the patients, not like handing them off to the OBs, but keeping them engaged, making sure that those rehabilitation and functional status optimization needs are met is important.
That was such a fantastic answer. And one thing you just mentioned, one of the more challenging topics to stay on top of is this explosion of treatment options and how that impacts counseling on breastfeeding. So what did you find about breastfeeding rates over time? What do you think it means, and why do you think that is?
I'm so glad you asked about breastfeeding, because it really is one of these important things, both recognized by the WHO as really important for the health overall of the mother and of the baby, but also, as we've seen in these past decades, that breastfeeding seems to have some protection against postpartum inflammatory activity, both relapses and new lesions. And so we wanted to look at breastfeeding in these cohorts. And overall, 71% of the cohort did initiate breastfeeding, which is pretty similar to national averages. Again, we couldn't compare very specifically, but it's pretty in line with general practices. And the median duration of breastfeeding was 6 months. So it's really nice to see that many patients were able to follow guidance, recommendations around breastfeeding for quite a few months. Still, many patients did choose not to breastfeed, and in about half of the cases, the respondents said that MS was the primary reason, and they were specifically having to pick between breastfeeding and starting their MS therapies. And that's a choice that we've been really trying to prevent patients from having to make, trying to give them support and knowledge around therapies that they actually could take while they're breastfeeding so they could really optimize their own likelihood of having a relapse-free postpartum period, and then also optimize their ability to reach, if they want to, their breastfeeding goals.
In light of the findings of this survey, for those of us caring for women with MS, what opportunities exist to enhance the counseling and support we provide when it comes to pregnancy and family planning?
I think the first thing is we have to remember that we owe it to our patients and that there are some helpful guidelines out there. So not to have the learned helplessness that, oh, I'm not an expert, therefore I'm not doing it at all. I think when we avoid that responsibility, then patients go online and have access to all kinds of useful and also not useful information. So I think the first is just to remember that it's part of the landscape of clinical care that we provide patients of childbearing potential. There is a lot of guidance out there now that people can access. And so as MS neurologists, when we're working with general neurologists, we really try to disseminate that information as best we can so that it can be accessible and useful to general neurologists in practice. I think keeping in mind the preconception planning, the pregnancy period, and then the postpartum period as another period where patients really need support is important. And always thinking about the collaborative care model where the neurologist may not have all the answers, but they can reach out to the lactation expert, the pediatrician, the OBGYN, and together come up with a comprehensive approach. It's really disappointing to me when I spend a lot of time working with a patient during their pregnancy, and then they get perhaps competing advice from people who are other parts of the care team. And so really having communication amongst members of the care team is critical for patients to be able to make their best decision and to stick to it and feel supported. I think that's a key thing as well. And then contributing to research, I think, is really important so we can continue to move the field forward. And just, it's so exciting to see, again, that practices change in response to research. Continuing here and not dropping that ball is important as well.
Riley, thank you so much. I mean, this has been just an enormous data dump and so educational on such an important but challenging topic. Again, the article is titled Multiple Sclerosis and Family Planning, a survey study of patient experience found in Neurology Clinical Practice. Thank you again, Riley, for joining us. That has been today's Neurology Podcast.
It's my pleasure. Thank you.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.